I would like to invite Professor Véronique Minard-Colin, who is Professor of Pediatrics in the Children and Adolescents Oncology Department of Gustave Roussy, Villejuif, France. She completed her medical studies in immunology and a fellowship in the Thomas Tender. Professor Minard-Colin has dedicated her research, clinical and training activities to non-Hodgkin's lymphoma, soft tissue sarcoma, and immunotherapy for children and adolescents with cancer. Professor Minard-Colin is the international coordinator of the trial testing rituximab in children and adolescents with high-risk mature B NHL and rituximab in relapsed refractory ALK, anaplastic large cell lymphoma. She's also the chair of the steering committee of the first international phase 2 Novartis sponsored trial with CD19 CAR-T cells in relapsed refractory mature Vita NHL, and the French coordinator of the international FR-RMSC trial in rhabdomyosarcoma. In 2019, she was elected vice president of the French Society of Childhood Cancers. Professor Minard-Colin is author and co-author of more than 120 publications referred in PubMed. She will present to us the success, failures, and challenges in immunotherapy in pediatric malignancies. Professor Colin, the floor is yours. Thank you.
Thank you for your very nice introduction. I would like to thank the organizers for inviting me, with a special thank to Louise, of course, our wonderful and so energetic friend from Cyprus. So I will try to give you an overview of the last immunotherapy development in pediatric cancers. Please, here are my disclosures. What do we know about immune surveillance of pediatric cancer? If I think about the general picture, first, we know that pediatric cancer have low tumor mutation burden when compared with adult. Here is a publication, a very famous publication from our German colleague, and here are adult cancer with a median mutation per megabase of 2. If you compare with pediatric cancer on the left, with a median mutation burden per megabase of 0.1, even at relapse. Of course, you see some patients with high mutation burden. We will talk about that later. There are patients with specific genetic predisposition. If we do the math, we know that about 4 mutations make a single epitope. We expect to have just 1 to 4 epitopes per pediatric tumor. So we expect pediatric tumor to have low immunogenicity, at least low T-cell immune surveillance. Second, we reported on others that pediatric tumors are cold tumors with very few T-cell infiltrates. Here is a French study, so-called ImmunoACT, with immune microenvironment analysis of pediatric cancer at relapse. The vast majority have very low T-cell infiltrate, with some exception. The majority have low B-cell count, very few, if any, NK cells, and the main immune population are macrophages of M2 phenotype, so a regulatory phenotype. We also know since about 10 years that pediatric cancer do have low expression of PD-1, PD-L1, such famous checkpoint. And finally, I just want to tell us that carcinogenesis occurs simultaneously with the maturation of the immune system, and immunity varies with age. Usually, the young ones have few effector cells with a polarization of the immunity in regulatory cells with macrophages, CD4, Treg cells, and tolerogenic dendritic cells. For example, just an example with the neuroblastoma, which is famous on about 10% of pediatric cancer, mainly in the young ones. We have several reports last year that show that, for example, the innate immune system is very important in the immune surveillance when compared with the adapted immune system. First, it has been shown that CD16 positive NK cell frequencies correlate with the chemo resistance. At low level you have, as more chemo resistance you observe. Second, we reported that the relative expression of the stimulatory and inhibitory receptor of NKp30 may influence survival in patients with high-risk neuroblastoma. Finally, the last 2 years, it has been reported that intratumoral dendritic cells is associated with a better prognosis in neuroblastoma. And we are working more and more to macrophages population. And with the last single-cell analysis, we show that there are specific macrophages. We should be able to target these macrophages with specific signature and subset that may play a key role in immune surveillance of neuroblastoma. If we think, so this is just a general picture, low mutation, very few T cell infiltrate, mainly innate cells. If we think about cancer immunotherapy, some target the tumor, some target the immune cells, some target both. We had some big success in pediatric cancer we will share with you, but we have still a lot of challenges. First, a monoclonal antibody, the most easier drug to access if we think about immunotherapy. There are different mechanisms of action, and when you use monoclonal antibody, you have to think about mechanism of action. It could block a growth factor. It could engage antibody-dependent cellular cytotoxicity or phagocytosis, such as anti-CD20, very famous, and it could block immune checkpoint. We will talk, of course, about that, such as anti-CTLA4 and anti-PD-1. They do have different origin. It's important when we think about toxicity. They do have different formulation. We will think about that. And they're so easy to access when compared with specific T-cell therapy. We had two big successes, I would say, in pediatric solid tumor. I will not talk about leukemia in my talk, and lymphoma. Of course, the last one was anti-CD20, rituximab story in high-risk B-cell non-Hodgkin lymphoma. It was an international collaboration, and we showed that when you add rituximab to conventional chemotherapy in high-risk BNHL, mainly Burkitt in children, you reach outstanding survival with more than 95% of children with Burkitt that survive for the moment. And the second success, I would say, is anti-GD2. You may know GD2, which is a ganglioside, which is expressed by the cells, the normal cells of the neural tissue, but also several tumors, such as neuroblastoma. And it's a nice development, but maybe not fast enough, I would say. It has been used in maintenance therapy for high-risk patients with success. We really hope we will be able to use it in combination with chemotherapy in induction, and we reach out very nice response rate in combination with chemotherapy in relapse. So I really think anti-GD2 therapy will be a future success also in neuroblastoma, but also in other GD2 tumors, such as sarcoma. We also had some success with, so I like the word smart chemotherapy. The adult oncologists use more and more this word. It's monoclonal antibody conjugated with some chemotherapy. The best and the first example is so-called brentuximab vedotin, which is anti-CD30 combined with auristatin, which is an alkaloid agent. It's very potent in Hodgkin disease and anaplastic lymphoma. The big question, it's for sure much more expensive than chemotherapy. The big question, is it more efficacious than chemotherapy and less toxic than chemotherapy? It is not for such sure for the moment, at least in Hodgkin. But in anaplastic lymphoma, it has been reported this year by our colleague from COG. It reached, in combination with chemo, very nice survivors. And I think this is also, it will be developed, I really hope, next year in pediatric sarcoma. B7H3, it's a checkpoint which is expressed on the cell surface of a lot of sarcoma, and it's combined with some radiation, and both have been reported to have great efficacy in some specific sarcoma, such so-called desmoplastic sarcoma. And there are a lot of new antibodies that have been developed, such as B-specific T-cell enhancer, dual antibody, etc., etc. They do have several advantages. They are so easy to access when compared again with CAR-T cell, for example. They may have better tissue penetration, and they may have better safety profile. I just want to illustrate by one example. He's so-called Wyatt. He wants me to share his picture. He had a primary refractory Burkitt on the cervical huge mass. He received chemotherapy with no efficacy. He received CAR-T cell, CD19 CAR-T cell, with some efficacy but progress by 2 months. And he has been treated with a bispecific T-cell enhancer, so-called glofitamab, with a very fast and rapid and complete response by 2 months. And 1 year after the relapse, he's in complete remission and he's doing so well and he's going at school, etc. So monoclonal antibody, we speak about conjugated monoclonal antibody, and the monoclonal antibody, of course, can block the immune checkpoints that play a major role in immune surveillance. We call them the brake of the immune system. They do play a role in the priming phase, but also in the effector phase, such as CTL4 for the priming, and mainly PD-L1, but several others. They remove the brakes, so they are expressed at the cell surface as brake of the immune response. So if you block this brake, you remove the brakes. Of course, this is a revolution in adult oncology. They are developed in thousands, I would say thousands of combinations, but pediatric cancers are different from adult cancer. Immune checkpoint blockers, they revigorate the pre-existing cytolytic T cells with native specificity for tumor-associated antigen. So immune checkpoint blocker function depends on, first, the availability of tumor-associated neoantigen, and you remember, few antigens in pediatric cancer, the endogenous T-cell infiltrate, and you remember, few T-cell infiltrate, and the PD-1, PD-L1 expression of course, other biomarkers. We were so depressed by the results in pediatric cancer. The first phase 1 has been reported by Gustave in North America with a phase 1 with ipilimumab, which is an anti-CTL4 with no response except for some melanoma patients. And several phase 1 and phase 2 have been reported the last 2 years with anti-PD-1 or anti-PD-L1 such as atezolizumab. We had an international meeting and we thought, okay, 350 children and adolescents have been included in this phase 1 and 2, but the response rate, apart from some lymphoma and some specific disease, was less than 5% if you compare with adult. So the main tumor that did respond to anti-PD-1, PD-L1 were adult-type tumor if we don't think about lymphoma. And okay, we didn't observe that much response, but we have some experience with hyper-progressive disease. This is just an example with a Wilms tumor, a patient. She was 10 years old with a complete remission at the end of 2015. She relapsed, unfortunately, 2 months later with a mass in the peritoneal abdominal region. She has been treated with atezolizumab, so anti-PD-L1. And, she just relapsed 2 months, but not so fast. And 4 weeks after, the volume was 10, and then she died a few weeks later. We are sure we did observe hyper-progressive disease on anti-PD-1 as adults observe in some specific disease. So a lot of deception, but some big success, mainly in lymphoma, such as Hodgkin disease, mediastinal lymphoma, and ALK-positive anaplastic lymphoma. And here is really a revolution. I like also to illustrate with Arthur. He is a 13-year-old boy with a primary refractory Hodgkin lymphoma. When I was young, I remember this child died of the disease, because it's about 2% of them, so it's very rare, but he received a very intense chemotherapy with just progression of the disease. He has been treated with nivolumab, anti-PD-1, plus rituximab vedotin with a complete metabolic response. It was about 4 years ago. He's doing very well, and he's still in complete remission, so it's just a revolution. PD-L1, PD-L2, it's a hallmark of Hodgkin lymphoma, and it's associated with the intrinsic immune resistance. Indeed, you observe in Hodgkin lymphoma 9p24 amplification. It's just where is expressed PD-L1. And, if you have anomaly of the NP24 region, you have just increased amplification of PD-L1 and immune evasion. You also have abnormality on JAK2 signaling pathway, which in turn PD-L1 also amplification. So it's really a hallmark of the Hodgkin disease. You have PD-L1 and PD-L2 expression in the disease. Anti-PD-1 will improve the cure rates for the very rare, but they're here, refractory cases. And we will think in the future, it will help to minimize long-term morbidity and mortality. We have an international trial in progress for high-risk Hodgkin patients, and we try to avoid radiation therapy for this patient and combine anti-PD-1 plus chemotherapy to decrease the number of patients who will be irradiated. So I will say anti-PD-1 in Hodgkin, it just changed the disease journey. And this is a rare disease, but we are very interested by this disease. It's ALK-positive anaplastic lymphoma. Just to illustrate, Ryan, it was the second patient. The first one, sorry, was a German patient treated by Villejuif in Germany. Ryan was 17 years old. He just progressed after chemotherapy. He just progressed after ALK inhibitor. He had no match donor. We treated with anti-PD-1, nivolumab. And he had such a rapid response because, he was on morphine because of refractory pain. In 2 days, we stopped morphine. In 1 week, he left the hospital and played football. So it's so fast. You observe very rapidly the response. He had a clinical improvement. We treated him for 2 years. We stopped in 2018. He's still in complete remission. So we have a trial also with anti-PD-1 nivolumab, phase 2, with 2 different cohorts. The first one is just for patients with refractory disease. The second one is more interesting, is to try to consolidate the remission with anti-PD-1 immunotherapy instead of allogenic stem cell transplantation in the disease, again to decrease the level of long-term morbidity associated with the transplantation. And finally, Hodgkin, anaplastic large cell lymphoma, and this is a specific predisposition syndrome, so-called mismatch repair deficiency syndrome. Of course, you know about the mismatch repair machines that play a key role for maintaining the genome stability. You know, of course, about the Lynch disease with one single allele, which is mutated, and you observe usually the median age at diagnosis around 50 years, with a lot of publication on many patients with GI and GU cancer. We know less about congenital or biallelic mismatch repair deficiency. Patients do have 2 mutations, 2 hits. The median age at diagnosis is 9 years. We don't know very well the rate, the incidence of such deficiency, but when you look at the patient, you find the patient. You have consanguinity is quite frequent because you have 2 alleles that are mutated, and we think it's 1%. I think it's probably more. And when we think about predisposition, I like the talk from Louis because predisposition, we can think about prevention, of course. But in this case, if you have to look to this syndrome to think about immunotherapy. So predisposition is also important for therapy decision. There are very few publications, less than 50. Patients have consanguinity, multiple childhood cancer with brain tumor, high-grade glioma, GI cancers, probably later on, around 15, 20 years, and lymphoma. And these tumors are very special because they are hot tumors with a lot of T cells, CD3, CD8, FOXP3 T cells, a high immunoscore, a repertoire Th1 with effectory memory T cells, sorry, it's in French, that high cytokine and chemokines. And as you understand, they have a high rate of immunogenicity. And this is amazing because these patients, the first one, have been reported by the team from Eric Buffet in Canada. And they were twins with high-grade glioma, one relapse after radiation therapy. She has been treated with nivolumab with a complete response. So mismatch repair deficiency is very, very important to look at to decide about therapy. And I have also one patient, he was 18 years old with a primary refractory sarcoma. We perform a biopsy of the large tumor and observe an important T-cell infiltrate. We looked at PD-L1, it was positive, and we look at MLH1, he had a MLH1 mutation. He just developed metastasis on chemotherapy. We have treated him with nivolumab plus pazopanib and radiation therapy. He is still in complete remission 4 years ago, which is just amazing when you think about primary refractory disease. So we have an international meeting and discuss together how to develop immune checkpoint blocker in pediatric oncology. They are mainly active, as you understood, in lymphoma and hypermutated disease. We may think, of course, of several development in combination with synthetic immunotherapy, such as CAR-T cells. There are a lot of CAR-T cell program in addition, in combination with anti-PD-1 to help for the persistence of the response. I will not talk about that. But if we think about the development of anti-PD-1, we do not need anymore any phase 1 or phase 2 with any new anti-PD-1. We know it will not work in pediatric cancer. It could work in combination with smart therapy, such as biology-driven combination, example, PARP inhibitor plus anti-PD-1. Or we may think also, I just want to tell you about this publication about an oncolytic virus that turned the cold tumor in hot tumor, which is very nice story from the American Boston team, which SSV1 immunotherapy in some brain tumor. Finally, 2 slides to talk about CAR-T cell. I will not talk about CAR-T cell in leukemia, and of course you heard about the revolution of CAR-T cell in hematologic malignancies, mainly leukemia. You know about Emily Whitehead, she was patient 1 about 10 years ago. I think next year we will hear a lot about this patient, 10 years after the first CD19 CAR-T cell infusion. She's still doing very well. What do we know about edited T-cell therapy? We know there are different cell therapy. It could be CAR-T cell, it could be TCR edited T cells, it could be NK cells, it could be macrophages, it could be several cells that could be edited to be more active to kill the tumor cells. This is a massive growth during the last years. It's a slide that have been shared by Crystal Markal. Very early result, but a lot of advancement and growth during the last 5 years. Very few results in solid tumor. You know, of course, they do have specific toxicities with cytokine release syndrome, neurotoxicity, some on-target off-tumor toxicity. But again, very few and very early results in solid tumor. Just one slide. This is our experience with one patient with CD19 CAR-T cell and a Burkitt lymphoma. You know, she had such a great response 1 month after infusion, but unfortunately she relapsed a few months later, so it was not such a success. The Chinese group reported a very nice results with a different CD19, CD20, CD22 CAR-T cell in Burkitt patient, and they just updated and published a few weeks ago 23 patients with an 18 months of PFS of about 80% with this CAR-T cell in relapse and refractory Burkitt, which is very interesting. We still have a lot of work to do. We have also some data, very early data with GD2 CAR-T cell in neuroblastoma, mainly data from our North American colleague, but also from Italy and UK, with some response that have been reported. We have more recent data in brain tumors, so-called high-grade glioma, with GD2 CAR-T cells that are injected locally in the disease, but very early. And I would say we have more data with sarcoma, mainly adult sarcoma, with some CAR-T cell, HER2 CAR-T cell in pediatric sarcoma, a nice response from a few patients, but also TCR-edited T cells who just target MAGE4, which is a great antigen, with some outstanding response, and the phase 2 is in progress. We had just recently 1 patient in this trial. So in conclusion, there is specific immune surveillance of pediatric cancer, low mutation tumor burden, cold tumors. Innate immune cells are the main immune cells in the tumor. We have to work on them, especially on macrophages. We had some big success with monoclonal antibody, of course, CD20, GD2, CD3. Other monoclonal antibody, ADC, BiTE, we for sure develop in the next year. We have some we have poor activity of immune checkpoint blockers in the majority of pediatric cancer, except lymphoma and hypermutated disease. And the edited cell therapy, such as CAR or TCR, we have very few and early results, several challenges, toxicity, trafficking, exhaustion, etc. But for sure, this is just the beginning. Thank you.
Thank you, Professor Minard-Colin, for the excellent presentation. We have time for only one question. Are there any questions? No, thank you very much.